Acute esophageal necrosis is a rare disease that is poorly understood. It is characterized endoscopically predominantly by black, circumferential, necrotic appearing esophageal mucosa that most commonly involves the distal third esophagus and spares the gastroesophageal junction. It arises from ischemic injury to the esophageal mucosa during low blood flow states. Hello, my name is Dr. Roberto Colon. I'm a senior internal medicine resident at Mayo Clinic, Rochester, and I'm accompanied by my colleague, Dr. Amrit Kamboj. He's a senior gastroenterology fellow also here at Mayo Clinic, Rochester, and we worked under the guidance of Dr. Cadman Leggett. And we are happy to talk about our article that will be in a future issue of the Mayo Clinic Proceedings titled Acute Esophageal Necrosis, a retrospective cohort study highlighting the Mayo Clinic experience. Unfortunately, our understanding of this disease is very limited to a few case series on the literature, involving only a small number of patients.
We conducted a single-center retrospective cohort study of patients diagnosed with acute esophageal necrosis at Mayo Clinic between 1996 and 2021. Data was collected on patient clinical characteristics, as well as the endoscopic and histopathology findings.
So in terms of the results, the study consisted of 79 patients with acute esophageal necrosis, with median age of 64 years, and 67% of the cohort were men. A history of current or former smoking and alcohol use was present in 60% and 67% respectively. The most common comorbidities included hypertension, dyslipidemia, GERD, coronary artery disease, and diabetes mellitus.
The most common presenting symptoms were hematemesis, present in 62%, abdominal pain in 37%, and melena in 25%. The most common triggering event for development of acute esophageal necrosis was shock. And this could be septic, hemorrhagic, cardiogenic, or non-hemorrhagic hypovolemic shock. And this was present in 62%, followed by post-surgical complications as a triggering event in 19%. Nearly half had a coexisting infection or bacteremia.
The 30 and 90-day mortality was 24% and 32% respectively. Patient age, sex, smoking, or alcohol use or associated comorbidities did not predict death at 30 days. However, the presence of infection or bacteremia was significantly associated with death at 90 days. Additionally, the length of esophageal involvement significantly correlated with the duration of the hospitalization.
Endoscopically, involvement of the distal third esophagus only was observed in 32%, distal 2/3 only in 40%, and the entire esophagus was involved in 29%. The endoscopic appearance of the esophageal mucosa ranged from predominantly white appearing mucosa, as shown in panel A, mixed white and black mucosa, as shown in panels B and C, and predominantly black mucosa, as shown in panel D. Sloughing of the esophagus was present in 41%, and this can be seen in panels E and F. 39 patients had a follow-up upper endoscopy, of which 26 or 67% had resolution, while 5 had persistent acute esophageal necrosis, of which 4 showed improvement from initial endoscopy exam. 18% of patients developed esophageal strictures during follow-up.
So for patients with the acute esophageal necrosis, some of them we obtained biopsy samples, and under histologic examination, nearly all showed diffuse necrosis and or ulceration, which is shown on panel A. In cases with necrosis and ulceration, 13 or 52% had fibrin thrombi within the small vessels associated with the areas of ulceration and necrosis. So this is shown on panel B. And 12 or 48% had brown or black pigments within the necrotic debris. 4 cases had fungal organisms, and this is shown on panel C, highlighted by the arrow, identified within the necrotic debris. No other infectious organisms, including viral inclusions, were seen. In conclusion, Acute esophageal necrosis is a serious condition observed in critically ill patients. Its endoscopic appearance can be highly variable, ranging from predominantly white to predominantly black appearing mucosa. In patients with an unclear diagnosis, obtaining esophageal biopsies may be helpful given the characteristic histologic findings. Thank you very much.
Thank you for your time and attention. If you would like to learn more about this topic, we would invite you to read our article that will be featured on the upcoming edition of Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.